Good afternoon and welcome to Insights in AI virtual series. My name is Sohail Khan, and on behalf of the RapidAI team, we want to thank you for joining us. We're excited to have Dr. Vishal Jani here to share his insight on how his program utilizes RapidAI to optimize transfer and treatment decisions, as well as improve ICH score reporting. In addition to sharing his perspective, our goal here today is to build a network for peer-to-peer interaction and learning, and to inspire you to think about how AI can be used to improve patient outcomes within your community. At any time during the presentation, we encourage you to submit questions in the Q&A box on the left side of your screen. It is an honor to have Dr. Jani here to lead this discussion. Dr. Jani is a system stroke and neurointervention medical director for CHI Health Hospitals in Nebraska. He completed his neurology training at Michigan State University, followed by a fellowship in vascular neurology and neurointerventional surgery. He's also an associate professor within the Department of Neurology at Creighton University School of Medicine. With that, I'll turn the floor over to you, Dr. Jani.
Thank you, Sohail, and thank you, the Rapid team, to invite me to share some of my thoughts and insight on how AI is helping our patients in the state of Nebraska. Greetings, esteemed colleague and healthcare partners. My name is Vishal Jani, and today we'll be sharing some idea and thoughts surrounding what this new era of stroke care look like using artificial intelligence. These days, artificial intelligence is not primarily a tool to screen the patient, but it's truly redefining the patient care. And we have firsthand experience about this technology, how it has honored the dignity of our stroke patients. I believe it's not just about outcomes, it's about quality of those outcomes, ensuring that every single patient, regardless of where they are, can hope for a better future. With that, we'll take a dive in, and I'll share some of the details about my practice. I am based out of Omaha, Nebraska in CHI Health, and we are committed to our stroke patients. In 2016, I joined the health system to start the program with a vision that every single patient to receive not just the ideal and optimal stroke care, but to preserve their dignity irrespective where they belong in the state. Our network is expansive, and it has multiple primary stroke centers, thrombectomy capable center, and comprehensive stroke centers. And I'll show you in details in the next slide. But we are designed to check our resilience and responsiveness and critical handling of these unpredictable nature of stroke. And in these kind of setting, integration is very important as we need to save time to preserve brain function. This slide, you can see the geographical presence of our health system and our hospitals. In the center, you can see we are based out of Omaha, and you can see all those red dots, and those are the hospitals in further west of Nebraska and eastern Iowa. One of our farthest geographical distance through which we are able to offer stroke care is approximately 4 to 5 hour driving distance. Now, in the face of geographical challenge, the critical golden hour for effective stroke care, it is important for us to be innovative utilizing artificial intelligence and the new technology because it's about equality. For those who practice in rural states where the nearest thrombectomy center or a comprehensive stroke center may be several hours away, artificial intelligence can bridge this vast divide, offering swift and accurate diagnostics, which is crucial for the time-sensitive treatment. Now, it is important to understand that our goal is to reduce the disparity by utilizing technology so we can bring consistency in life-saving treatments to all communities, regardless of their location. Now, our stroke program is built on three pillars: clinical excellence, operational efficiency, and financial viability. All these three elements are important to understand for physician leaders, hospital administrations, and also coordinator and healthcare provider, partly because it is very instrumental to make a right decision that enhances your speed and accuracy for stroke care, which in turn improves our service delivery and patient outcome while ensuring program remains sustainable. Now, how we have been able to achieve clinical excellence through artificial intelligence. Now, the concept of this technology precision meant that care teams can move swiftly, can make a decision that is based on appropriate information, and avoiding futile treatments and focusing on what would truly make a difference in that patient. This is the essence of clinical excellence, where technology and compassion meets. Now in this slide, as you can see, there are three different details. On the farthest left, you can see the intracerebral hemorrhage module, which is a module that detects the presence of cerebral hemorrhage. In the middle part, what you see is hyperdensity module. Not only detects, but outlines the location of hemorrhage and automatically calculates the volume. Along with that, artificial intelligence also has an ability to detect subdural hematoma, and we'll review those details individually. Now, hemorrhagic stroke is one of the issue in neurological space. It's an important critical health issue, but the innovation has lagged behind. And with the help of AI technology, we wish to bridge the gap. So let's understand some of the facts. Stroke is an expensive disease. It will cost approximately around $103 billion to take care of our stroke patients. Now that accounts for direct healthcare cost and indirect healthcare cost, which is due to loss of productivity and increased mortality. Now, this technology is not just innovative, but it's essential in my opinion, because not only it excels with a very high sensitivity and high specificity in diagnosing these disease condition, but also it does it in timely fashion so we can be very effective in the golden hour. Now, the data is so precise that it basically literally translates in saving the life because our actions are measurable now. Now, one thing I want to point out is why this is important. The reason this part is important is because there are certain aspects of hemorrhagic condition that we are unaware. What future holds, there are many unknowns about hemorrhagic condition, which basically, besides we have to be quick and we have to be accurate, there are many aspects that will be decided in the future. So we wish to make sure that every single patient gets a chance at the right time. Now, I want to share one of the example of how this module helps patients. Now, the most complex issue in hemorrhagic condition is hematoma expansion. Hematoma expansion essentially meaning when patient has initial sentinel bleed, and following that, if for some unclear reason, if that bleed gets larger, that is the concept and the holy grail of why our field of hemorrhagic stroke hasn't grown as fast as ischemic stroke, because it's quite complex. But I think we should be committed to mastering the simplicity of what each patient deserves while we unfold why hematoma expansion happens. Now, this example, what you see is a patient on the left hand where patient presented to one of our thrombectomy capable center, received the initial CT scan, and the module detected 43 ml of blood. And based on its location, we're able to quickly triage the patient and transfer to our tertiary care center, which has our surgical subspecialty. And we were able to do that effectively and quickly. Now, one third of the cases, one third of the patient who has hematoma will experience hematoma expansion, which potentially can be a key driver in both mortality and healthcare cost. Our ability to compare and detect every single small hematoma or expansion very objectively is of very importance. Partly because this in particular field of hemorrhagic condition, I believe what is missing is the objectivity of communication. Many times you'll hear that there's a patient who has a kind of bleed with GCS of this, or maybe some neurological condition explained to the receiving facility or the provider, while we are unable to truly understand the volume of that bleed, partly because it is a manual process. And missing elements of measuring and conveying those facts between healthcare providers sometimes leads to an unclear picture where we miss those cases where potentially hematoma expansion can happen and can lead to poor outcome. With this module, there is an automation. So with that, not only you are able to detect the hemorrhage and you're able to quantify the volume of the blood, but you are able to compare the actual uh, volume following the transfer in the full spectrum of care wherever patient is transferred. So it brings a lot of objectivity. Now I'll show you these stability scan and how the patient evolves. So upon arrival, patient underwent series of uh, stability scans. And upon understanding increasing volume, patient was able to receive the treatment. And based on the treatment, what you see is objective measurement of resolution of blood, and that resolution and appropriate treatment, timely treatment, resulted in improvement in patient care. This is a simple example where by just demonstrating the objective facts of volume and our quick action and its quick translation to improvement in patient care can be easily visualized and can easily be replicated if we establish a consistent process of screening these patients. Now, we will dive into subdural hematoma, which is one of the modules that RapidAI has developed. We have not used it, but it is at the forefront of neurological treatment, partly because there are new trials that suggested that treatment of subdural hematoma with middle meningeal artery embolization seems to be extremely effective. Not only it reduces the recurrence, but it also has mortality benefit, meaning subdural hematoma should be detected and be treated using these new treatment modalities. Now, to streamline the process, artificial intelligence algorithm is important. And the reason I say that is because, as you can see, one third of the patient potentially can die if they remain untreated, and one third of the patient potentially will lose follow-up because we were not able to identify and funnel them to appropriate level of care, especially in larger health system or geographical distances and some of the challenges of referral pattern in a larger market. So in that case, I want to share a personal example. In our practice, based on the total volume of stroke, we have done only 9% of the patient, approximately 9% of the patient that has been treated using middle meningeal artery embolization, where you can see that larger portion of the patient either were not able to come to us um, or they chose not to come to us because they could not understand the idea of treatment. Now, how do we maximize our efficiency in this space to translate the social impact we can make? Because obviously that financial impact is fairly profound, as you can see, but it's a very common condition. So its social impact has a tremendous value as well. Now, our network and its operational efficiency meant patient could receive a care without unnecessary delay or transfer. This efficiency is not just about saving time, it's about saving lives and making every single second count. Now, enhancing the patient transition with AI in hub and spoke model is very important. And I want to highlight how AI has changed that spectrum and paradigm of transition of these patients across the healthcare network. Our objective is clear: to ensure no patient is left behind, regardless of their location. By leveraging AI, we have created a seamless and consistent pathway for screening and for transferring patients from our community hospitals and our sister hospitals to our comprehensive stroke center. This is not just about logistics. It's about our commitment to provide a dignified care through our hub and spoke model, which ensures every single patient who receives ICH screening gets appropriate level of care without any delay. It has a secondary implication as well: development of the EICU initiative in part of a broader strategy to reach out to critical access hospitals remotely and offering the same level of compassionate care if patient does not qualify to be transferred to the comprehensive stroke center. In pursuing clinical excellence, we must remember that there is a human element, and it's not solely about treating a medical condition. It's about nurturing the spirit of our patients, ensuring that dignity and compassion are at the forefront of everything we do. It has been quoted that 20% of the patients that gets transferred to a higher level of care potentially can be avoided. Those transfers can be avoided. And that has a financial implication as well. 20% of the patients potentially can stay in their primary hospital of its origin and potentially can reduce the cost burden. By keeping patient to its primary location and transferring the patient to appropriate level of care. Along with that, we also want to make sure that those patient who needs to be transferred continues to be transferred throughout our spectrum of care in our medical network. Now, as you can see, that identifying the patient, communication via AI platform between two hospitals and provider, and decision of treatment and transfer seems to be seamless, and most of you have seen it. But there are ways to track those patients all the way until it reaches to rehabilitation, including the way we measure door in, door out time to optimize our operational efficiency that translates into good patient care. Now, I want to share a story about the challenges of our daily details to maintain our compliance how we document things, and we wish to kind of take an example of something that we utilize this module to improve our efficiency. We, before we began our journey to become comprehensive, had a challenge to document our ICH score, which is one of the element and a requirement for any comprehensive stroke center. And by deploying the technology using appropriate education, utilizing appropriate path of champions, coaching all the spectrum, all the care spectrum leaders, from a very low number, we are able to reach to almost consistent 100% compliance in a very short time. Now, the result of that improved compliance and the result of that compliance resulting in improved patient outcome, which is our hypothesis, yet to be determined, and we are looking into that. But we felt very intrigued with the idea that utilizing technology, we are able to improve a human behavior and medical decisioning seamlessly. And we actually submitted an abstract in ESOC, in European Stroke Conference, that we'll be presenting in the upcoming few weeks. My team will be presenting those data. Now, ICH patient care story also needs an understanding of financial viability. Utilizing this platform, not only we are enhancing patient care, but also we are ensuring that our interventions are cost effective, ensuring its sustainability and the ability to invest in future innovation. Now, one other thing I want to share with you, as any program that kind of goes through a comprehensive journey that utilizes artificial intelligence and utilizes its technology at its peak, will see a growth because you're able to transfer appropriate care, appropriate patients seamlessly to your comprehensive stroke center. We started our journey initially with a low number, but as you can see, our growth trajectory continues after utilizing artificial intelligence technology, and we have become more efficient in our patient care. One of the most important part that is worth looking into, as it is our daily detail of how we manage these conditions. And the very simple way to measure the detail is length of stay. Obviously, our adoption of all the module is fairly relatively new. While we collect and obtain a very refined data, a very crude detail of this length of stay graph between 2 years, 2022 and 2023, shows a trend that is favorable, meaning our length of stay seems to shrink. And we estimate, based on our raw data, that approximately 3 to 5 days of length of stay potentially can be saved upon further refining our data, which we will be presenting at some point. Now, imagine a scenario where AI technology is applied to stroke care, and system could increase the number of treatment of the stroke patients, especially in intracerebral hemorrhage. But I want to make you understand exactly some of the financial modeling that is proprietary to RapidAI, and the experts potentially can guide you based on your institution's financial details and number of patients. But it is based on what exactly it brings on the table. In a simple way, it actually cost saving by limiting the futile transfer. Anybody who can stay to a regional hospital can stay based on the screening methodology, and any individual who needs a comprehensive level of care should be transferred, along with appropriate surgical intervention, timely surgical intervention, and quick response, potentially shrinking length of stay. When you combine these elements, it potentially can bring a large impact, a large potential return on investment, which the company executives can help you to understand. But this is just a scenario to understand exactly the yield of the technology in a financial spectrum. Now, we are not stopping there, and the future is bright. There are so many advancements that are coming, and I feel lucky to be a part of the workforce who is able to make a change on a daily basis. And these modules that are coming in the future, whether it is visualization of the full arch starting from all the way up to the chest, tracking those arteries in 3D, or looking at those arteries in three-dimensional rotating field, along with some of the logistics of tracking and measurements all the way in different part of the body. So I feel that company RapidAI is going beyond just a stroke, and they have done a tremendous job in identifying and quantifying and handling vascular disease throughout the body. So it's a broader characterization and qualification beyond head and neck only. With that, I will stop, and I thank you for attending this webinar and understanding of what is my personalized experience and my team's experience in impacting patient care within our health system. I want to acknowledge my colleagues, my partners, my coordinators, and my administration for allowing us to deliver the care we are able to deliver. Thank you again, and I wish you well.
Thank you, Dr. Jani. Now, we will address a few questions that came in during the presentation.
Sure.
So first question, how did ICH scores help you standardize your decision-making?
ICH score decision-making is, as most of you who knows ICH score, it's a tool that we utilize to define the prognostication of the patient depending on the size of the hemorrhage. And essentially, it is a simple fact that it is an objective risk stratification. It has a very clear, consistent treatment decision and trajectory decision based on the score that most healthcare provider will decide. It also offers very clear communication between provider and timely communication. And most importantly, it allows us to take evidence-based approach based on the objective ICH score that is unbiased.
Thank you. What are key indicators that you use to determine transfer decisions for ICH patients?
Yeah, that's a great question. So I assume the question is, what is the protocol and how do we handle some of the transfer? So I'm a neurologist and interventional neurologist, and I work with my colleague neurosurgical team who are at the forefront of determining the transfer. But my understanding is, logically, the decisioning of any neurological condition, including intracerebral hemorrhage, is primarily dependent on the clinical status of the patient, the characteristic of the intracerebral hemorrhage, meaning size, location, and extent of bleed, and need of very specialized detail like midline shift, and those kind of details. And along with that, the third element is need for specific intervention, which can be gauged using these image viewing platform virtually. And what I mean by that is need for angiography, need for EVD placement, need for hemicraniectomy. And along with that, we also want to understand availability of surgical and critical care team at the sending facility, along with comorbid condition. So it's a kind of hodgepodge of multiple details that we will need to understand, but we need to understand quickly and then decide if patient needs to come to comprehensive care unit. Seems like we're having a small technical challenge. Apologies for that. I'm looking at the questions and I'll try to answer some of the questions that have been sent. One of the questions is, how did we overcome the paradigm shift in our network to transfer the patient with bleeding? And I assume the question is pertaining to how we're handling our ICH patient and transfer.
Hi, can you hear me?
Yes, we can hear you. Well. Hello. Training our providers, physician, nursing staff, and behind the scene about ICH score, making a decision, how to calculate. And we are also trying to develop a protocol where it has a succinct, objective understanding of how patient care protocol should look like, along with identifying champions who can coach other leaders and department leaders can help. And also kind of looking at some of the pilot studies where some of the details of what the pain points are, like ICH score documentation, or some other details in the care spectrum can be managed utilizing this time trackable details using AI technology.
Hey, Dr. Jani, can you hear me now?
Yes, we can, Sohail.
Yeah, the final question I have, how did you convince administrators that rapid ICH and hyperdensity is a worthwhile investment within your institution?
Well, I think the simple answer is all of us are on the same team. And we have to understand that we have to speak common language. Just like the ICH module allows us to communicate objectively, we have to speak freely with our administration partner. And the way we have done that is by highlighting the clinical benefits in terms of what it means to have these documentation, early identification, and those details, and its potential clinical benefit. It is very important to make the team understand the financial impact that I showed, as it definitely has cost effectiveness and it has been studied. The third thing is standard of care. Now, I do understand the ICH and the standard of care is as a moving target, and there are so many details that are changing and evolving. But I think it's a leap of faith. We do have to redefine the standards and make everybody understand about unknowns and the trajectory we wish to take, which is clinical excellence. I think, overall, if we cover the clinical, financial, and strategic consideration, where institutional goals are aligned to the highest quality care and standard, I don't think that it should be difficult for any leader to explain the need for these technologies.
Great. A lot of questions come in. One more here. How does your hub and spoke facilities utilize the mobile communication platform?
We have a transfer center which connects all our providers based on the disease segment, whether it's ischemic stroke, the hemorrhagic stroke, based on the protocol and training they have. We're able to remotely review those images utilizing the phone platform. And we are able to also communicate via text platform built in within the app as well. So depending on the preference, we are able to utilize all three in isolation or altogether.
Great. Can you explain how these modules have helped in non-stroke patients?
Many times, non-stroke patient, this stroke mimics are quite common. Almost 20-25% of the patient who comes to the hospital will go through investigation, stroke treatment, and triage. And timely treatment is very important. So I think it actually has helped them quite a bit, because these technology and these modules are so sensitive that it gives confidence to multiple team member for timely disposition for patients who does not need to be in the hospital. For example, if patient comes in with dizziness and we're trying to figure out if patient has any ischemic stroke or hemorrhagic stroke, utilizing this platform and their ability to accurately detect those details and provide patient an accurate confirmation that we have reviewed the images within 6 minutes or 7 minutes and it looks okay, brings a tremendous value, because radiology colleagues are also overwhelmed reading multiple different details. So I think it empowers multiple team member, including resident physician, hospital medicine physician, ER physician, to at least give them preliminary understanding and kind of redefining the standards of staying in the ER.
Great. I think we have time for one more question. For the implementation of each of these solutions, was there a learning curve, and how did the different teams approach these challenges and learning curves?
We have been utilizing RapidAI platform for a few more years before we adopted the hemorrhagic module. So the integration and interface was well known to the team members. So when we introduced the hemorrhagic module, it was no different. It is very intuitive. We coached all the providers who are involved in the spectrum of care, whether ICU team, resident physicians, coordinators, neurology residents, neurology attendings, about utilizing this particular module. And as I have shown in those images, it's very simple to read exactly what's the core look like, what the penumbra looks like in ischemic stroke, or in hemorrhagic condition, how big is the volume, and those kind of details. So we did not struggle too much to educate the team, because the team already knew the interface.
Great. That's all we have time for today. Thank you, Dr. Jani, for sharing your invaluable insights with us. And thank you to everyone who joined us today in this engaging discussion. If you'd like to continue this conversation, please submit your information in the lower right box on your screen, and we will connect with you as soon as possible. Lastly, please join us again on June 18th to hear more insights in AI from Dr. Dan Gibson, who will speak on building a system-wide stroke program with AI, which you can register by clicking on the top right box of your screen. And thank you again. Thank you, Dr. Jani, and have a wonderful evening.
Thank you for the opportunity. Thank you all.